So next, we're going to be hearing from Dr. Amanda Simanek. So Dr. Simanek is a social epidemiologist. She is the founding director of the Michael Reese Foundation Center for Health Equity Research at the Rosalind Franklin University of Medicine and Science. And her research focuses on understanding these critical pathways that lead from social disadvantage to health inequity. And I think today she's going to talk to us about something that I think is a really interesting and very plausible hypothesis of the idea that some of these pathways may have to do with microbes and infectious disease. So please.
Thank you. Always good to understand and engage the audience for reception to this idea. So that I have at least one, maybe others. Thank you, everyone. I'm excited to be joining everyone here today to have a chance to hear your thoughts on this hypothesis and to learn about all the other great work that everyone is doing related to understanding social inequity in Alzheimer's disease. So my work as a social epidemiologist has focused largely on trying to identify the novel biologic pathways by which living in, being born into, and living in social environments of social inequities impacts chronic disease across the life course. And I primarily focused on a biological mediator, particularly the role that social patterning of infections, persistent pathogens may play in shaping outcomes like cardiovascular disease, cognitive impairment, depression. So I have not looked at specifically, but I have looked at a number of conditions related to Alzheimer's risk. So today I'll talk about what I mean by persistent pathogens. I'll give an overview of what my colleagues have found regarding social patterning of these infections. Overview some of the particular questions that I've asked related to cognitive depression and talk about what the implications might be then for social inequities. Of course, we observe these patterns in other conditions. I'll advance in this little. Any tech first left. Well, while we're doing that, okay. This was an advancement.
That's report. Okay, or the space bar, either or.
Oh, space. Okay. And so I will say too, before I joined at Rosalind Franklin University as their founding director of their Center for Health Equity Research, I was at University of Wisconsin-Milwaukee. So I will echo Dr. Stark contrast to the day before when I fell in my driveway slipping on ice and blizzard at the time of school drop off. So I'm for that reasons too. So what are persistent pathogens? I'm talking about viruses, viruses, bacteria, and parasites that once you are infected with them, persist in the body, either can enter latency and reactivate, or for bacteria will persist if they are not treated, or it's parasitic infections. So things like herpes viruses, cytomegalovirus, herpes simplex 1 and 2, Epstein-Barr virus, bacterial pylori, and parasitic infections like Toxoplasma gondii. And so these infections have been of interest to me because of their capacity to cause damage to different tissues and organs of the body over time, to kind of wreak havoc on the immune system, inflammatory pathways or alterations to sort of cells of the T cell compartment, etc. And I have spent a good part of my research studying them in relation to chronic disease outcomes for that reason. The other reason that they have been of interest to me is because of the strong social patterning of these infections in the population and their capacity, therefore, to explain social inequities in chronic disease. And so I'm going to give a little overview of some of the findings that others have published related to the social patterning across socioeconomic status, race, ethnicity, and gender in relation to exposure to these types of pathogens, the transmission dynamics of these pathogens, and how well we immunologically control them. So this is a compilation of data from several different papers of researchers that have used data from the National Health Nutrition Examination Survey to look at just the seroprevalence or indicator presence of IgG antibodies against these pathogens at the population level. And so these are different waves of NHANES in slightly different age groups, but you see a consistent theme across CMV, HSV1, H. pylori, and Toxoplasma gondii, that if you have lower income, you are non-Hispanic, Black, or Mexican American race ethnicity, and for herpes viruses, if you are female, that you have a higher seroprevalence at the population level of these infections. That pattern is slightly different for Helicobacter pylori and Toxoplasma gondii, where men are at have greater seroprevalence. And so we take this as an indicator of differential exposure to these infections. Oops, I don't know how to go back. Okay, in terms of social patterning of transmission, this is adapted from a paper by Coordinati et al. From 2008, again using data from NHANES. This is just focusing on cytomegalovirus, but it looks at the force of infection, or the spontaneous per capita rate of acquisition of infection, the reproductive rate, which maybe we're all familiar with now related to COVID, in terms of the secondary number of infections that are generated from a single case into a susceptible population, as well as the average age of acquisition. And we find the same similar patterning of those that are low income, non-Hispanic, Black, Mexican American race ethnicity, and female gender are more likely to have a higher force of infection, to have a higher reproductive rate, and to have, importantly, a lower average age of acquisition of these infections, which could have impact on how we immunologically control these infections. I'm not loud enough. Okay. Thanks. This is from a paper by colleagues Dowd and Avillo et al. Again, using data from NHANES. You'll see a theme here that this is one of the national data sets that allows us to look at prevalence and relationship between these infections and other chronic disease outcomes that is available. And so this is showing the IgG antibody level, which for herpes viruses, if we see an elevated IgG antibody level, we take that as an indication of poor cell-mediated immune control of that infection, that it's reactivating and causing an antibody response. And so what we see here is across different ages, that there's strong socioeconomic gradients here. So the bottom quartile in blue is the bottom quartile of income, and we see higher antibody levels against that pathogen, and we see that across the Lifecourse. Similar themes have been shown, patterns have been shown across race, ethnicity, and at the intersection of socioeconomic status and race, ethnicity, and across gender, and even at earlier ages. This is 25 and older, but these patterns have been seen as early as childhood. And so, oops. The takeaway here is that we see individuals that are facing the social structural determinants of health, living in environments of poverty, that are from experiencing social and structural racism, and living in areas of concentrated poverty, and then dynamic of gender roles as well, determining who is likely to get exposed to these infections, who is susceptible to these infections, the rate of transmission within their communities, the likelihood that you get infected at a younger age, and that you have poor immune control of these pathogens over time and over the life course. And so taken together, this really makes these infections a prime candidate for explaining some social inequities in chronic disease, if in fact they are related to those chronic disease outcomes. Sorry, back again. And so While I have not looked at these infections myself, others have looked at them in relation to Alzheimer's disease. We know that there are social inequities in Alzheimer's disease. And there's decades of evidence now sort of pointing to persistent pathogens having a role, particularly herpes viruses, in Alzheimer's disease etiology. Acknowledging some mixed findings from 2 recent Mendelian randomization studies. And I asked Dr. Devanand if he's going to be talking about his phase 3 trials, looking at the impact of vesicular liver on AD and kind of impairment. Those are still pending. So there's still some outstanding questions for sure. But the same mechanisms of being able to infect the brain, cause damage to tissues of the brain, cause impacts through neural inflammation may be relevant to cognitive impairment, even outside of AD. But certainly cognitive impairment itself is a risk factor for, or is concomitant with AD. And so it's of interest to understand if these pathogens have a role in shaping cognitive impairment. And so there has been, I'd say in the last decade, studies looking more so at specifically cognitive impairment. And so 2 of the questions that I've specifically asked is there evidence that there's an association between pathogens like herpes viruses and cognitive impairment emerging early in life? Because most of the studies that look at AD or even cognitive impairment are restricted to individuals of middle to older age. And then if we think about the role that cognitive reserve can play potentially in buffering the adverse effects of risk factors on AD, then the other question that I worked on with others recently is asking, does education level modify the association between herpes viruses and cognitive impairment in older age? And the 2 study populations that we looked at these questions in are the National Health and Nutrition Examination Survey and the Health and Retirement Study. So first in NHANES, like I said, this study has one of the largest population-based samples in which they have assessed seropositivity for these types of infections. In the 3rd wave of NHANES, they also did a number of cognitive assessments of different age groups. So children aged 6 to 16, they administered the WISC-R, RAT-R, so assessed math, reading, and other cognitive function tests like block design and digit span score. In middle-aged adults, they did central nervous system testing, simple reaction time tests, symbol digit substitution test, serial digit learning test, and in older adults, the mini mental state exam. So we looked at in a cross-section across these different groups, whether seropositivity to these viruses is associated with these cognitive function tests. And we adjusted for a number of covariates: age, gender, race, ethnicity, country of origin, census region, smoke exposure in children, smoking status in adults, and also SES variables. And what we found is that among kids who are 12 to 16 years old, herpes simplex virus 1 seropositivity was already associated with lower reading score and lower spatial reasoning score. In middle-aged adults, HSV1 and CMV was associated with impaired coding speed, and CMV seropositivity with impaired learning and recall. And in older adults, only HSV1 seropositivity was strongly associated with immediate memory impairment compared to those that are seronegative. Regarding the next question, and then I'll do sort of a summary of what I think the next steps forward are here. We asked in the health and retirement study whether CMV seropositivity as well as IgG antibody level, which again is a marker of immune control of these infections, is associated with cognitive impairment. So this is a large cohort that started decades ago, but in 2016 they assessed cognitive assessment as well as did a venous blood draw that allowed for the assessment of these pathogens. The outcome here was global cognition, a continuous score, and we looked at this across strata of education level. And what we found is that in age-adjusted models, there was a strong relationship between CMV seropositivity as well as CMV IgG level and lower scores on this cognitive test. This was attenuated after additional adjustment for age, sex, and race, ethnicity, and education level. And then when stratified across education level, we saw a pattern consistent with those with less than high school education having the most severe impacts of CMV on their global cognition. So I think these, the findings from our study in Haynes suggest that herpes virus infection may be able to contribute to cognitive impairment early in life, or different cognitive measures. I don't think that's necessarily a surprise, given the role that we know that HSV, for instance, can play in other outcomes like encephalitis, and the role of congenital CMV and cognitive function in children. However, I think it's important to study what happens and when people acquire these infections, knowing that there's social gradients in the average age of acquisition. And to my knowledge, since we published it, there's only been one other longitudinal study but that study looked at CMV and HSV1 and found that HSV1 was linked to memory function, but not CMV among adolescents. So I think it's a understudied age group in which to understand the early impacts of these infections on cognitive function. But that we need to look at them, over time, which is challenging, right? To be able to enroll kids, look at seroconversion and look at these types of measures over time, which does make that challenging. In terms of understanding the role of cognitive reserve, I think that's also challenging, because we really need to know about the timing of acquisition of infection. When you have sero studies that just show IgG antibody level, you don't know when that person was exposed, right? So if we think education in part or social gradients exist in who gets infected, of course, then education is sort of a precursor to potentially getting infected, or your family's socioeconomic status, which makes education sort of a predictor as well as a modifier of these relationships. And so these things need to be further teased apart. So the other outcome I'm going to talk about is mood disorders. And we know there are vast social inequities in both the prevalence, who gets diagnosed with mood disorders, but then among those who are diagnosed, in the severity of depression. This is well documented. So depressive symptoms are also common in AD. Recent meta-analysis, also suggests it may be a prodromal sign or risk factor for AD. So it really begs the question to think about the role that these infections might play in the etiology of depression and how that might be related to Alzheimer's disease. So when I started this line of research, there were a number of cross-sectional studies that examined the association between persistent pathogens and depression, but mostly among older and small clinical cohorts. And so questions that were outstanding to me at that time were, what is the longitudinal association between, persistent pathogens and new onset of depression? The primary pathway or major pathway is thought to be through systemic inflammation, the impact that inflammation has on different aspects of neurotransmission, as well as sickness behavior. And so I think studies that are cross-sectional weren't fully able to assess that pathway as well. And then knowing that that women are twice as likely to experience depression, are there differences between the relationship between persistent pathogens, inflammation, and depression across men and women? And then, because a lot of these studies have been conducted in older populations, do we observe these associations beginning earlier in the life course? So these are some of the questions that we tackled. To do this, I used data from the Detroit Neighborhood Health Study, the Sacramento Latino Study on Aging, and then the National Health and Nutrition Examination Survey. So in the Detroit Neighborhood Health Study, this is a longitudinal cohort of about 1,500 Detroit residents that helped carry out it all at University of Michigan from 2008 to 2013. It's PI'd by Dr. Allison Aiello. And we were able to assess at baseline among a subset of these individuals whether they were seropositive to HSV and CMV, as well as a few other pathogens, both seropositivity and IgG antibody level. The outcome here was depression onset at wave 2 of the study. And so we restricted to those that had no history of depression at wave 1. This was about 263 people left in this study population. We looked at CMV as a mediator and IL-6 as a mediator as well. And we adjusted for a range of factors: age, gender, race, education level, income level, as well as history of traumatic events, alcohol use, smoking status, and also medication use, both antidepressant as well as non-steroidal anti-inflammatory medication use at wave 1. And what we found was that individuals that had elevated CMV IgG antibody levels had over 3 times higher odds of incident depression over the first year of the study. We did not detect an association with HSV seropositivity or IgG level. We did not also detect that inflammation was a key pathway of interest here. So the herpes virus was not associated with inflammation at baseline, and those inflammatory markers did not predict incident depression. So, I'll comment later on what I think, we need to do in terms of assessing further these inflammatory markers. In the SALSA study, this is a longitudinal cohort of about 1,800 Sacramento area Latinos. We again limited our population to those that were free of depressive symptoms at baseline, and that were tested for persistent pathogens. So this time we looked at CMV, HSV, varicella zoster, Toxoplasma gondii, as well as H. pylori, both IgG level or seropositivity and IgG antibody level. And we assessed over a course of 6 follow-up points, whether they at that time had elevated depressive symptoms or between waves had been prescribed antidepressant medications as an indicator for onset of depression. And we looked at C-reactive protein interleukin 6 as mediators. We looked at whether this varied across men and women and adjusted for similar factors as previous study. And what we found was that out of all of these pathogens, only CMV seropositivity was statistically significantly associated with increased odds of depression. And the total sample was a marginal association, but among women was a strong association, was statistically significant. Again, we saw some correlation with CMV and inflammation, but those inflammatory markers as measured at wave 1 were not predictive of onset of depression across this 6 waves of follow-up. And then last, we looked at this in a slightly younger population, 15 to 39 years of age, using data from NHANES again. And so in this wave of NHANES 3, they assessed lifetime history of not just depression, but also dysthymia and bipolar disorder based on DSM-3 criteria. And then they had assessed individuals for seropositivity to HSV, CMV, and H. pylori, and then a subset of the women only had IgG levels for antibodies against CMV. We adjusted for similar covariates as previous studies. What we found here was that H. pylori seropositivity was associated with increased odds of dysthymia among women, but surprisingly decreased odds among men, which was not an expected finding. CMV seropositivity was also associated with lower odds of depression among men. And then among women that had IgG levels available, this was marginally associated with increased odds of mood disorders among women. No associations between these pathogens and C-reactive protein, and C-reactive protein was only associated with depression and dysthymia among men. So the studies that I mentioned here were the first 2 longitudinal studies to assess this role of infections in depression. There was a consistent lack of median effects or inflammatory markers, which could be a product of the way they're measured, their half-life, and sort of not being optimally captured in these studies. We saw some evidence for gender differences in the association between these pathogens and depression, although I think the protective effects in younger men need to be explored further. Since these studies came out, there have been another study using NHANES data that kind of found similar patterns for CMV, but did not stratify across men and women. Other studies have looked at gender differences in HSV2's impact on depression, which I think have to be taken in the context that people that have HSV2 are more aware of their infection status and suffer sort of social consequences of those infections in ways that people that have CMV or HSV1 may not, because they may not be aware of their infection. But those studies have showed a stronger effect in women. And so I think on the whole, if we know that there's social patterning of these infections, and we know that they maybe have a role in depression, and they may be able to be something that explains social inequities in AD. And then we also know there are gender differences, you know, in Alzheimer's disease as well that are worth exploring further in relation to these infections. So I want to acknowledge and thank many collaborators, Dr. Elsa Aiello is PI of many of the studies from which these data come from, as well as a cadre of other individuals that were co-authors on these papers. And I'm happy to take questions, give feedback. I'm really interested in what the sense is of maybe what the impact of these infections could be in this pathway. So thank you.
We may have time for one question.
There is actually a question. So this.
Okay, I'll read it. Yes.
Yeah.
So herpes virus infections are very common. It would be interesting to see what is the connection between HSV and education and potentially reducing the risk of ADRD or cognitive decline. Perhaps there are other confounders that should be studied as well. Yeah, I mean, I think these are observational studies, you know, which is why I pointed to some of the Mendelian randomization studies or the trials that are coming out that are looking at treatment of herpes viruses in relation to these outcomes, though they're mainly looking at this in older populations. And so I think these are highly prevalent infections, but the way at the age at which we acquire them is different across social factors, and the way we immunologically control them is different. And so that's where we may see some of that variation in the impact of these infections on such outcomes.
Okay, one more quick question.
Yeah, thanks for the very nice talk. I think your point about education and other factors is critical, because if you look at the epidemiological studies on herpes simplex virus, some of the European studies don't find a strong association. American studies sort of in between. And the strongest association was found in an electronic record study from Taiwan, where the people who were treated with antiviral drugs had 9 times less risk of getting dementia than people who weren't. So I think while looking at individual factors is useful, I think it's a general problem. Low education, socioeconomic status, it's associated with greater risk of infections, poorer compliance with treatment, and then you see these effects in epidemiological studies. And covariance analysis cannot fully address that, even from a statistical methodological standpoint and practically. So I think, you know, this is an area where one can actually do clinical trials, which we're doing. And I think for a lot of these questions, randomized clinical trials with the same population, you know, the people entering from the same population is really critical to address these confounds, which come up in some studies, as you showed. Sometimes they don't come up in other studies. Very hard to.
Yeah, exactly. I mean, in the range of studies, there's a range of things that people adjusted for. We try to be very rigorous in our adjustment, but that is not always the case. And of course, there's always unmeasured confounding. So I look forward to what happens with your trials, Dr. Devina.